Hi, welcome to the study of cardiology. This is Dr. Jaitly. Here I'm talking to you about what is atrial flutter. It's an arrhythmia which commonly or usually exists with atrial fibrillation, and if atrial flutter is left untreated, will degenerate into atrial fibrillation eventually. So it is a fairly irregular rhythm where the ventricle rate is about half the rate of the atrial contractions. Now, we know the atrial fibrillation originates around the pulmonary veins in these areas of the roof of the left atrium where the pulmonary veins are connected. However, atrial flutter is located as a short circuit, which is a re-entrant type of mechanism, going in an anti-clockwise fashion, as I show you in the left panel here. It is situated right next to the tricuspid valve. These are the three leaflets of the valve. The isthmus, which is the junction between the atrium and the ventricles, and the inferior vena cava. So it is exactly here that the re-entrant circuit is established for whatever predisposing reasons we will just talk about, and that transmits impulses at almost 240 to 340 cycles per second, and as a result, almost half of them will be transmitted via the AV node, because AV node is like a filter here. So when it conducts almost half the rate. So you should see about 150 more or less as the ventricular rate, which is very uncomfortable for the patient, by the way. 150 at rest is very, very uncomfortable. So the patient will complain of significant palpitations, dizziness or lightheadedness at times, chest pain and breathing difficulty can occur, and that's because the heart rate is extremely rapid. Profuse sweating, and then symptoms and signs of other conditions accompanying it, like the diabetes, for instance, the pulmonary diseases, obesity, hypertension. There might be thyroid disease. Congenital heart disease are the causes of atrial flutter. Sometimes we see that even after post-op CT surgery, cardiothoracic surgery. It may be a manifestation as part of a sixth sinus syndrome, which I'm going to discuss at a different video vignette. But just to let you know, on an EKG, it'll appear as F waves, which will be in the inferior leads 2, 3, and AVF, will show positive F waves. Will show, negative F waves, and a positive F wave will be seen in V1, which is the top chest lead. Usually the conduction, as I said, is about 2 to 1. So say the atrial rate is about 300 or 320. The chances are the ventricular rate based on a 2 to 1 conduction will be 150 to 160. Management is clearly dependent on cardio by pharmacoconversion, specifically if the patient is hemodynamically stable. In other words, blood pressure is good, patient is not having chest pains, and there's no deterioration or no impending shock. One may try type 3 agents, which work the best, whereas for atrial fibrillation, type 1A drugs work the best. Anticoagulation is pretty much on the same guidelines as the atrial fibrillation. Cardioversion is required for hemodynamically unstable or the ones which are impending to go into a hemodynamic instability. And cardioversion is almost 90 to 100% times successful if used properly and in the right strength of the energy. And then radiofrequency ablation as a chronic therapy, which could be applied, and they ablate this area so that the short circuiting will never happen again and the patient stays in sinus. So on the right side, I've shown some rhythm patterns here. So atrial flutter is somewhere here, which is twice the rate of the normal, and of course then irregular beats are typical of atrial fibrillation at the bottom here, as I'm showing you. But the one in the black here are the atrial flutter waves, which is twice the rate of the normal beat. So here the heart rate was about 75, here the heart rate is about 150, for instance, and they have flutter waves because you can see flutter waves in between, and those are your F waves as commonly seen, because you'll have atrial rate, almost the flutter waves marching through these are complexes. Well, that summarizes a little discussion on atrial flutter, but please go ahead and supplement further information knowledge on articles, journals, and texts. And hope you enjoyed this part of the section as well. Looking forward to meeting you again on another video vignette. Thanks so much. Goodbye.